Dear Pure Urology viewers, good evening one and all. Today, even though topic is not surgical technique based, we are focusing on the some legal aspects. The one thing which you don't want to listen, you don't want to hear is a word death. But unfortunately, sometimes on-table death can happen. It may be because of the myocardial infarction. We think most of the times cardiopulmonary arrest, that's all. But anesthetic drugs will be there. There may be some excessive bleeding, but whatever it may be, the news to the first surgeon, this is pertaining to urology we are talking. This is to urologist, this is to the anesthetist, this is to the OT team. Everybody will be stunned when the death happens. That too, when you are not expected. Then, after that, how to face the attendance is one aspect. Second is, after that, how to take care of yourself legally. There are two aspects here. One, you will be sympathetic, you will talk to them, you will convey them, they overreact. All these, one needs to be experienced. For this, none other than in our country, the elect Urology Society of India President, Dr.Lalit Shah sir, to be honest, personally, he is a great well-wisher for all of us youngsters who is with us in many times. And even sometimes I also have asked him some legal, because when we are doing so many cases, sometimes legal notices will come. So I called him, and like that, many people call him and he helps. In fact, he is the past president, West Zone USI, and he is convener legal cell USI. First urologist of Chhattisgarh. He is very senior in that way. Special interest is reconstructive urology. He has seen all the olden days of large sheaths, large ureteroscope, complex urethroplasties. He is passionate for medico-legal education of doctors for their safety. Definitely, there is no doubt. And delivered more than 300 talks on these various urological topics. He helps friends and colleagues in defending their medical negligence cases, more than 150 cases. It's more like a social service. He is presently the consultant urologist at Jagiwan Urology Center, Raipur. I have been to Raipur 2 times and witnessed the entire Raipur Urology Society giving great welcome, and we have operated there also. And with this introduction, as I have less knowledge, I can only ask questions as a layman and try to interact with sir. Otherwise, sir is experienced. Let us listen. At least with this, all urologists must know what not to do when death happens. We will definitely be knowing it. Thank you very much, sir. Lalit Shah, sir, over to you. Thank you for accepting the invitation.
Thank you, Dr. Chandra, for a great introduction. And we'll continue with this one.
Yes, sir.
The topic today is death on operation table, how to manage. Now, death on operation table, like you said, is such a word. Whenever you listen about it, whenever you think about it, or whenever you read about it, you miss a couple of your heartbeats. Even today, right now, also, I'm having a couple of heartbeats missing. Because what happens is that the moment you think about it, whatever experience you have had of about your DOT or half DOT, they run in front of your eye just like a television replay. And you miss a couple of your heartbeats. That is the situation. See, the critical incident can occur in an operation table, and then there can be 3 outcomes. The first outcome can be that you with the help of anesthetist, have been able to do a successful reversal, 100% successful reversal. Second can be that the partial reversal is there, but because of the hypoxia, there is a hypoxic brain injury. And the third situation may be that you have not been able to revive at all. So why we are talking about it now? We are talking about all these things because since last maybe 20, 30 years, these issues have become more Consumer Protection Acts, the legal things, the cases are increasing too much, and all those things are there. There is no standard protocol for this because the surgery is being done since many, many years. But we were never talking about that. We are talking on all these sort of aspects only since last 30, 40 years. And we all believe in general that it can never happen to you. Unfortunately, it can happen to everybody. And when I say you, I mean we, and I am very much included in that. I am no different. See, the situation can occur in the three format. Number one is an unexpected, unpredictable, and unavoidable. Say, for example, you are doing a cold surgery of a hydrocele for a young person, and because of some reason or the other, there is a death on operation table and you are not able to revive. The second scenario can be where you know that there is a high risk. You have already done a counseling to the patient and their attendants, and they are willing to take the risk. It may be an emergency situation, it may be a not emergency situation. Maybe the cardiac problem is there, maybe respiratory problem is there, and unfortunately, the risk becomes a reality. So there the acceptation of by the patient is no more, unfortunately, but the attendant acceptance becomes much more. A third one aspect is that there are preventable medical errors. Now, in this situation, whenever there will be a death on the table and the matter goes to the litigation, whatever the fact may be that you, the anesthetists may know and the God only may know, but the attendant would always say that it was because of the preventable medical error, even though it may be from the first category, unexpected, unpredictable, and unavoidable, which you can probably not change even for your father, brother, mother, uncle, anybody. And similarly, the doctor would always say, though even if it is a preventable medical error, but the doctor in the hospital will always say that it was unexpected, unpredictable, and unavoidable. So to have this in one particular category would always be depending on the records that will be produced. Because your words against mine would nullify, so it will be only the records which will work for this. The first thing which occurs is a very simple thing. Our reaction is, oh God, what is happening? And there is a total blackout in the mind. So it is very, very important that the surgeon, being the leader of the team, should not panic. Now, there are few data that I would like to say. Million die from surgery each year. This is a WHO data, that too also in 2008. It said 7 million preventable surgical injuries. 1 million die during operation or after surgery. And one of the most important things, more than 50% of this injury and death are preventable. These data is too much dangerous. Now, another thing is the death of table can occur in various scenarios. It can be in a small nursing home or a big hospital, corporate hospital or institutes or medical colleges. It can be a high-risk case or an ordinary risk case. Another is cold and emergency cases. In emergency cases, to a certain extent, it becomes acceptable. In big hospitals, generally speaking, it does become acceptable to a certain extent. But a cold case and a small nursing home is a very, very toxic affair. Very, very toxic affair. For all practical purposes, not acceptable at all. In today's scenario, especially in India. So what is the sequence of event in general? Patient will come for surgery, you would do pre-op assessment, pre-op preparation, you take informed consent, then anesthesia, and then unfortunate DOT can occur. And that can lead to spot violence, police complaint, consumer forum, civil suit, medical council, multiple forum litigations can occur. The spot violence is basically a law and order problem. So you should be able to diagnose the trouble possible cases. You should have your dedicated group where, in case of requirement, when you feel that something wrong is happening, before breaking the news, you should be able to call your friends and colleagues from nearby area so as to help you. It is very important that you should inform the police that unexpected death has occurred and we are expecting some sort of a violence or unpleasantness situation there. And another thing is, many times it happens They call the police comes, but later on, the doctors and the small hospitals in general, that has been my experience, that they do not lodge the official complaint. They are afraid, I do not know what they are afraid, but they do not lodge the official complaint against the violence. They just accept it as like that. Another important thing is that we should have their CCTV camera and our security should be there, because in small nursing home, there would be probably only one doctor and one anesthetist, and that too in the operation theater, and maybe 10 staff, which may not be sufficient to handle the violent mob. The Delhi Government Hospital is keeping the bouncers. There is Prevention of Violence Act against the Medical Establishment Act, but in general, somehow the other, even the police do not register the case against this. If there is a violence, we should photograph the damaged property, inform the police. If the staff is injured, the medico-legal checking should be done, and the treatment preferably in the government hospital, and the record should be taken. We should have the insurance of the furniture and indemnity professional act should be there. Now, when the death occurs, what has been happening is that the attendant would go and complain to the police that doctor has been negligent and they have killed the patient. And then 304A would be registered against you. But fortunately, Supreme Court in various Suresh Gupta case, Jacob Matthew case, Martin case, have given a ruling that the doctor will not be arrested unless and until there is a prima facie evidence by a board of committee, preferably by the government doctor, where a specialty doctor is also there of the same specialty, and then only the arrest can occur. But in general, police do not follow this, and many of the police do not know, and many of the doctors also don't know such rules and regulation. Another one thing which has come over in last few years that I am seeing is that because of the lower pressure of the judiciary, local administration, politicians, and police and all that, rather than 304A, which is a bailable offense, they are registering the case, initial registration under 304. That means there would be no bail and the doctor will be put behind the bar. See, one of the things is there, say for example, you don't like my talk and you come and kill me. So there would be only one case against you, 302. But if the surgery is done and death on operation table is there, they can go to many forum at all. They can go to consumer forum, they can go to police, they can go to the civil court, they can go to the nursing home association, they can go to the medical council, and simultaneously everywhere the case against you would be running. That is a very, very unfortunate situation. If you anticipate a trouble, it is better that you inform the police and you call the police before they call the police. And now we come back to the internal management. Resuscitation, we have to do that. So there should be 6-step management. The first thing is, most of the time it becomes very difficult for us to accept that a critical incident has occurred. We must accept that the critical incident has occurred. A rapid assessment of ABC should be there, airways, breathing, and circulation. We should always ask for help without any hesitation. We should keep our ego aside. Call for our own colleague, call for extra anesthetist help. These are all things very, very important, especially in a small and medium nursing home where there are not plenty of help available. In a big hospital or a corporate hospital, a multi-specialty hospital, a medical college, there are plenty of help is available immediately. So they would be able to guide you for assessment, management, and as well as record keeping. The surgeon should stop operation if it is feasible. Assessment and treatment to continue following the ABCD protocol, and at various stages, you should pause and reassess. It will be better that the new person is assessing it or reassessing.
Sir, one question here. While doing the ABC, should we alert the attendants or not necessary? Should we call them inside or not necessary? Sorry.
I am coming to that. I will come to that. Okay. And then it is very, very important that the help which is coming should be doing the completion of records. Because what happens is, say for example, that there is an issue and the police comes and they say they would seize your record. They may or may not give you sufficient time to write down your notes, because at that point in time, if you are short of hand, so whether you would be doing a resuscitation or you would be recording the notes. So that is also very important, that you should get the help so as to put the records, completion of the record. The management, like I said, preparedness should be there. We should not panic. 6 protocol. If it is possible, you should have the mock drill, train your staff, and then you should communicate to relations gradually. When the first thing, minimum of initial 5-10 minutes, whatever resuscitation you have done, put in an endotracheal tube or resuscitation and all, reassessment is there. Some of the friends have come. It may be in a multi-specialty hospital, they may be from the neighboring operation table only. When it is there, then only you should inform the attendant that such things have happened. We are trying to improve the situation and all that. And that is the point where you can bring up the attendants to see inside whether, if they see what attempts you are making, so many people have collected, and operation theater is the best possible place for resuscitation. Then the things get cooled down. But such things may or may not be possible in a large hospital or a medical college setup and all that. But for small and medium nursing homes, these situations and these type of activities do help to a certain extent. Then it is very, very important that we must communicate to staff, that the communication, the staff should not go out and do some rubbish. This one, they may not be doing it on this intentionally rubbish, but it may turn out to be rubbish. They said, no, the blood pressure has gone down, it has become 0, but the doctors have done right, and now it has come to 50, it will come back to 120 and all that. No problem. They should not talk like this. Your communication should be by the senior doctor or a senior staff, not by the general staff. And then when you are calling somebody out, before that, you should set in the order. It should be reasonably clean, because we are used to seeing the blood all around, splashed around. Our drapes are red, our floor is red, and all this and that. But the attendants may not be that one. They would always feel just the patient has bled to death. So you should do a little bit of cleaning, blood stains, cover it with the drapes, fresh drapes. And then you should see that the oxygen cylinder is not empty. That is also very, very important, because that is what the attendants see, and that is what it comes, because the oxygen was not there, the patient has died. And then the endotracheal is in the trachea. That also we should ascertain. It's not that the endotracheal tube is in the esophagus. The MOP count should be there. And another very, very important thing is that the expiry date of the drug should be there. You should always have checked it. Adrenaline ampule is one of the things which is of a very short expiry date. And most of the operation theater, you would find, because they are not commonly used, they would remain of expiry date. And we know some of the cases where the doctors have been in trouble because of, when the police has come and done the seizure there, they take up all the ampules, and when they found that it was an expiry date one, there was a trouble for the doctor in the hospital. See, another thing is, unless until it is because of the massive bleeding on the operation table, it can be either the cardiac arrest or anaphylaxis. Whatever happens, you are doing the various steps, whatever at that point in time you and anesthetists are doing. But it is possible that it may or may not be proper. Your sequence may be going hayward here and there. So you should have the official, whatever is the textbook recommendation of the treatment of management of cardiac arrest and anaphylaxis pasted on the walls of your operation theater. So that when you are writing the notes, you should copy that notes. What we have done is a different thing altogether. But writing the note should be whatever is mentioned in the textbook. That sequence you should be very, very important, and you should take that. Because if there is a mistake in writing those notes and it is caught later on, it will be in trouble. And few of the nursing home has a very, very common thing that whatever is required, they would just, one staff will come out, write on a piece of paper and give it to the attendant. Get it from the pharmacy. It is very, very important that the emergency drug should never, ever be asked, because that would give a very, very bad impression and create a lot of trouble. You should have an adequate supply in the operation theater for the emergency drug. You cannot have anybody coming out and writing on a piece of paper, get an adrenaline ampule. That's terrible. But I have seen it happening in many of the cases. That's what I am saying, that it is very, very important, if it is possible, to have a separate emergency staff team so that they have a fixed protocol for CPR. Otherwise, everybody is confused and we do not know in a proper manner. Everybody should know their role. It is a well-defined one so that there is no confusion and a proper CPR is done. Another thing is that anesthetist needs an emotional support after critical incidents. So he should not take routine cases for 24 hours if it is in a smaller nursing home. And second critical incidents, if it unfortunately occurs within 24 hours, it may not be as bad as for the patient, but it may be very bad and very, very bad for the anesthetist. So in general, we recommend, unless until it is a government hospital or a medical college where the things are different, the anesthetist should not take any case, cold case, for next 24 hours. And similarly, the surgeon should not also continue. As my practice, fortunately, there have been no DOT in this 40 years of my experience, but there have been half DOT, which we have been able to reverse them completely. And I have been following the practice of canceling all my operation list on that particular day and telling my patients, okay, we would keep for one day, we have postponed because of this situation. Of course, we would not be charging for one day extra and all that. Most of the patients have accepted because I do not want to go ahead and do the surgery. So now another thing, what happens is many times the surgeon, when you have a successful reversal, the surgeon has a tendency to go ahead and do the surgery because then he does not have to tell the patient and attendant that the problem has occurred. But that is not proper. That is not proper because you might have been able to reverse the heart rate and the respiration and the blood pressure, but his homeostasis might have been disturbed to a great extent, and that may not be very well for the continuation of anesthesia and surgery. So it is better that don't continue the operation if the arrest has occurred before the operation. Then another thing, like I said, should they continue the list? It is an individual thing. In a medical college and a corporate hospital, probably the things may not be easy, but in individual nursing homes and all that, that is what I follow. And I would recommend that one should close the list every day and take the risk for that particular day. Another thing is surgeon and anesthetist. What happens is later on when the case goes to the court, and say, for example, you had not done the incision, that is where the problem occurs. The surgeon have a tendency to say that, see, I have not even started the surgery. But the patient has come to you. You are the leader of the team. And the patient has a rapport with this one. Patient has not come to the anesthetist. So you cannot be relieved from the responsibility. So they should work like a team and they should share the responsibility. And they should speak the same language. What has happened, why has happened, their version should not be different. And then another thing is that we should have a reliable group of anesthetists. The anesthetist calls another anesthetist when the situation is there, and he should be in a position to cancel his old cases and come to help you out, because it is I scratch your back and you scratch mine. So it doesn't matter if you cancel your cold cases if you have not started, but to help our own colleague, your physician, cardiologist, few other surgeons of your specialty, they should be able to come and help you out, because then if required, you would also go out and help them. Another thing which occurs is whether we should get a postmortem or not. Now, many times it happens that the patient's attendant would say that we do not want the postmortem. But if it is an unfortunate situation, if it is a high risk, which we have been able to explain, and the patient and attendant are reasonably convinced, and your sixth sense says that it is not going to be a problem, then the things are different. But in an unexpected death of any young patient, of a cold patient, you should always inform the police and ask for the postmortem. Because, say, for example, if the police comes and the attendant say that they do not want the postmortem, they would give Panchanama and that give them the dead body. You are on the safer ground. Because then whatever hypothesis you would talk about, the possible cause of death cannot be questioned because the no postmortem was done in spite of your request. So whatever philosophy that you would be giving, that this cardiac arrest has occurred, there was a drug reaction, X, Y, Z, whatever, that would not be challenged. That would be beneficial to you. So you should always ask for the postmortem. The written refusal by the patient's attendant, this question has been asked many times. So a patient attendant is given in writing that we do not want this one. It may have a moral pressure on the attendants, but that is legally not valid. It doesn't work. Another thing is, say, for example, you have been able to revive a patient. The patient is on endotracheal tube and artificial respiration. His cardiac activity and blood pressures are okay. But your hospital does not have an ICU or a cardiology sufficient, and you want to send it to some other hospital. Then shifting the patient will be, you must make sure, number one, where are you shifting? You should discuss with them that they are willing to accept the patient and they should have the available bed. Government hospital cannot refuse. That is very, very important. Now, the patient must be shifted in a well-equipped ambulance. This particular case was there where the LSCS was done, the blood turned dark, obstetrician informed the anesthetist, patient needed resuscitation, E-tube was passed, then E-tube was removed and patient was shifted to ICU. He became vegetable and hypoxia. What had happened was that the anesthetist did not accompany in the ambulance. He had a problem like he will go to that particular hospital, then how will he come back? So he went by the car following the ambulance, which is of no use because if he is not with the patient, whatever help required is there, any CPR required in ambulance, he would not be able to do that. So an anesthetist has not monitored in the ambulance. So what is the point of an anesthetist following this one? So the anesthetist was penalized. Documentation, we should make sure that preoperative workup is fine, PSE is fine, operating monitoring, operative drugs and post-operative care, whatever is there is properly documented. And whenever we talk about the record should not only be perspective, but it should also appear to be prospective rather than retrospective. It should not become too perfect because the court have given judgment in many times that if it is a too perfect record, they have written in the judgment that it was an afterthought and the record has been prepared later on. It is not a prospective record. It should not look like cooked and manipulated, should not be in the same handwriting, same pen and same ink with the same flow. That is what we do in general. So whatever happens is that the records are the judgment which occurs is the diagnosis and the contradictory note. The note should not be contradictory. Many times you would find that your notes, the nurse's notes, and the anesthetist notes are not matching each other. And that creates a problem. So you should be very careful onto that. Another thing is how long CPR should be done. Nowadays, the timing has been changed. I think probably it is about 10-15 minutes or so. Previously, it used to be around 30 minutes. So in one particular case, there is a judgment where the patient had operated, that is very short notes are written, operated, some procedure done. Next morning, 9 o'clock, the patient gets the call, there is no pulse, no BP. CPR started at 9 o'clock. And 9:10, the patient was certified because in spite of resuscitation, patient could not be revived. So there it was mentioned that the CPR was not done for the sufficient time. So we should have a good rapport with the patient, especially with the area police, local politician, and local press. If we do not have a good rapport, doesn't matter, but we should not have a negative rapport with them. Because what happens many times when the patient and attendant, you have been able to explain, but any local people may come and disturb this one. Another thing is the old timer versus new timers. The old generations are very touchy about this. The new generation take it very lightly and they take it on the very practical level. Some of them have become thick-skinned money-making record, which probably we are not. So it does make a difference to all of us. So death during LSCS, told surgery would be done in half an hour. Blood was needed, not arranged. 5 hours were lost in this one. Patient was serious, and during shifting, he died because of the massive hemorrhage. Death following hernia, it says that the cold surgery should be done during the operation time by the senior consultant, especially in high-risk cases. Poor pre-op preparation, here they did not arrange the cross-match blood. Patient was obese and they did not have the suitably long needle for the intracardiac one. That also is very, very important that you should have. This was documented. This is a wordings of the judgment. So prevention is obviously better than cure. Various checklists, informed consent, and all this should be there. Another thing, there are sometimes the half death in the operation table, fire in OR, explosion in OR, OT light falls on the patient falls from the table, bone fracture while patient transferred table to trolley or trolley to table. All these things have happened, and we should be careful to take care for this, because we have to understand that this is CPA, not DPA, Consumer Protection Pact. Though they say that the burden of proof is on the complainant, but for all practical purposes, unless until it is watertight from your side, you are in trouble. So take home message would be be honest to yourself and your patient, keep good medical records, always take informed consent, don't be a very good salesman in taking consent, have requisite qualification, don't take case beyond your capability, don't take case beyond the capability of your setup. Like my setup, I may be a good TUR receptionist, but my setup does not have a cardiac ICU. So I should not take a patient who is having ejection fraction of 20% for a TUR in my nursing home. I should take it to a corporate hospital where the facilities are available for cardiac ICU. And don't take any case without full workup. Don't hesitate to take second opinion, need to convert, need to open, or need to refer. Cover yourself and your hospital with professional risk management and indemnity insurance. And for God's sake, please prevent preventable surgical errors. Thank you. Thank you very much.
Thank you, sir. You closed too fast before. You did not give me chance. Nice.
No, we can discuss in between. No.
I did not know that adrenaline expires very fast. This is what I learned today. Second thing, I did not know that post-mortem I have in my 18 years, 2-3 cases, but I have not inquired. I have not ordered. I did not inform police. So at my level itself, I am deficient after running 17 years of 3 hospitals. So this presentation is very useful. Coming to the some doubts which I have.
Yeah, please.
If the attendance takes away the file before you write anything, because you should have some time to write. Nobody will write when the death happens. After 10-15 minutes, we may write retrospectively what we have done.
Correct.
But if they take the file, we want the file immediately, give it, they pull it out and take it out. Does it have any consequences?
No, if they have taken away the file, that means the file is no more with you. So that is what you would be informing the police. At that point, you have to make the notes of this. Whenever you are informing the police, naturally, when the file has been taken away, that means the situation is not very classy, not the one which is going to be solved by the understanding. So you are going to inform the police. When you inform the police in writing, at that point of time, you would say that the file have been snatched away by the attendants. So that particular thing would be able to save you in the court of law.
If some local MLA comes and try to influence to help the poor, okay, we don't mind helping them, but at not the cost of the doctor. It happens many times that local MLA come, what happened, why the patient has died, why they threaten you, and at that time police comes and if the situation is not very good for the hospital staff, especially owner, at that moment the hospital administrators will be talking. Can the primary surgeon, in case of a threatened situation when too many mob is there, is it wise to be away a little bit of time and then come back in the evening and talk?
Yeah. It is very important. See, you have to judge the situation. If you feel that there is a possibility of a physical violence to the surgeon, he should avoid facing this one. And that is where the local team works, in the sense that you call one friend and he called 10 friends, so that the 10 friends are available there. And they would be doing the talking. That is what we have been practicing in our city, that every area wise we have assigned few doctors. So for example, there is a problem in my nursing home, I will call only you. And then I'm not going to call 10 people. You would be able to call 10 people. So maybe 6-7 people will be able to come, and then they will call the general body, and the whole people from the city will collect their choice to help. That is what we need to do.
That's really great. If a patient attendance damages the hospital, is it a negative factor to them?
Of course, it is very, very negative, because as per the rules of this Prevention of Medical Establishment Act, which if you are able to file a complaint against them in this one and give them the documented proof, like I said, by CCTV camera, taking the photograph and getting your staff which is injured to this one, all these attendants would be in trouble. And it will help you in the court of law, and they would be punished. There have been instances where they have been put behind the bars.
If the surgeon by chance misses the file within 1 year, and you get the notice after 2 years that patient attendants have filed a case, and your file is not seen by chance. Nowadays, we take special precaution that that file will be in a separate almara, not in this thing. How many years file should be there in a death case? And if the file is not there, to what extent we will be in trouble? I mean, I should not ask this question, but something sometimes happens
Agreed.
after 1 or 2 years. If they come and inquire, initially they act, no problem, sir, thank you, sir, it's okay. But later on, one of their relative will tell that you go and put up the case, and they will put up the case because you'll get money, put up the case.
See, they can put up the case up to 2 years.
Up to 2 years.
Up to 2 years. This is the time of limitation. That is the rule. But another thing is there, that if they are able to convince the court that they have delayed, say for example, they come after 2.5 years, then they would invent some excuse that because of this reason we were not able to do that. And in general, you can understand that these people are willing to accept their version. All right. So that is what we are recommending. In such cases, we should keep these records minimum for 5 years safe. And to answer your another question, if say for example the file is missing, it is going to be a big problem for you. It is going to be a big problem, because court does not take a good view when they feel that you are hiding the fact. See, when it may be because of a genuine reason that the file is not available, but what they would feel is that you are hiding the facts. So in that situation, if it is possible and you are able to anticipate, before that, you should lodge a notice to the police that the file has been stolen away, or there has been a fire in the medical record department and these files have been burnt.
Okay.
This can probably help to a certain extent.
I understand. To circumvent the situation,
yes,
which is natural. We should not try to manipulate, but real truth we can.
Yes, correct.
If generator is not there during the time of death, by chance current goes, what is the and the patient attendant says that at that time current was not there. What are the situations when the current issue comes? Generator is one issue, lift is another issue. These two are dangerous situations. How should we?
Lift per se may not make too much a difference, because see, various states have their own nursing home acts. And as per their own nursing home acts, whatever is feasible or whatever is required, you should have that. Most of the nursing homes nowadays are insisting that you should have a generator. It may be a small generator and all that. If that is there, then
to support the ICU at least.
Yes. So if it is not there, there would be a problem. That's why you would see many times, even for the operation table, operation theater, the requirement, they say suction machine should be 2. Number 1 is electrical operated, another is a foot operated suction machine. At least in Chhattisgarh, the rules, regulations that they have mentioned, what are the minimum requirement should be there in the operation table, operation theater. If any nursing home is having an operation theater, what are the equipment minimum which is required?
Do you think that ventilator is also necessary?
Ventilator, at least in Chhattisgarh, it has not written up as far as the ventilator is concerned. It is not written. But if someone is running a reasonably good size hospital, it is better that they have.
Yeah. Whatever the basic ventilator, 5-6 lakhs also you can use.
Yeah, it doesn't matter.
For lifetime, it will be useful.
Yes.
Whatever because they won't get damaged. We don't use. They won't get damaged.
Yeah. It doesn't matter.
During the Corona times, we have taken each hospital multiple ventilators. They are there.
See what happens if you save the bill for that. That works and that helps.
Yes. Then really helps.
Yeah, that would be really helpful.
Okay. So if any child anesthesia during circumcision less than 4 years or 5 years, generally we are avoiding less than 2 years. Now we are giving treatment conservative. After 4 years to 5 years, that is the period where patient attendants will not accept.
Not at all.
Not at all. Because even our children also we will not accept, because child comes smiling, and if he has, then in those situations, can we really say a reason that we don't have mistake? Our own heart says that anesthetist might have gone. This is for the anesthetists who work limited period. For example, not all. After 5 years, 7 years only, I could hire a full-time anesthetist. If the full-time anesthetist is not there, and if the anesthetist goes after this thing, especially before the patient comes out of the theater, if the patient goes into deep sedation, and then somehow could not resuscitate, because the surgeon cannot do anything. So if this is not available and suddenly attendants know, we are caught in front, na? It's LBW.
Yeah. I understand. I'll tell you, see, I also am running a very small nursing home, 10-bedded hospital. And of late, there is no space to expansion, plus I am not interested, whatever, XYZ.
Yeah.
I would say my own experience, what has happened was, we did one pyelolithotomy. That fellow was a jovial, mildly obese, and he used to come with, this was 25 years ago, that I have only one, my wife, myself, one son, one daughter. We are only 4 people. And we have no big family and all that. My big family is somewhere else and all this and that. We did the surgery, and the patient was shifted to the ward, and we had 2 more small surgeries that we completed. And when we completed that, we came, naturally we take the round. Anesthetist was also with me. In front of our eyes, he started turning blue. And because the anesthetist was there, he could do the resuscitation.
Yeah.
In the ward itself, he could do the resuscitation, put in the endotracheal tube, shift it to the OR, and then we did the complete resuscitation. I am 100% sure if he was not there, I would have not been able to. 99% I might have not been able to do that. When hypoxia is there, the intubation becomes still more difficult. So I might have not been able, might have not been able to. So that is what I have made a practice, because I also do not have a regular anesthetist who would stay all the day with me. Yeah. They come for the case. So I have made it a very big rule, and especially if the patient is getting an anesthesia, not the spinal, but the general anesthesia, that he would not leave my campus before shifting of the patient to the ward, number 1. Number 2, after that, he has to take tea and some snacks with me, so as to spend at least 15 more minutes. So that, and then see the patient, and then only go. I tell him, if you want, there is no problem. I can pay you extra for this. That is not a big issue. But you cannot leave the hospital campus till we are satisfied that the patient is not going to go back into this one. Yeah,
this is very, very important, I think.
Yeah, especially in a small nursing homes where you don't have too much of help.
Yeah. So, last couple of questions. Professional indemnity policy, in your experience, how much and what company do you suggest? No conflicts of interest. This forum is very,
I understand. I don't have any conflict of interest with anyone.
See, more than 140 have attended this program as of now. Like
no issue. See, indemnity assurance, the quantum will depend on the socio-economical and financial educational standard of your patient. What is your general clientele? If it is for a very high this one, you should take minimum of 2 crores. But for an ordinary persons who are running a small and medium nursing home, and the clientele is not of a very high scale and all that, anywhere between 50 lakhs to 1 crore is good enough. And then nowadays, various professional indemnity things are there. You can take from anyone. It doesn't matter.
Anyone, no problem. No problem. So, for me, you will advise 2 crores.
Yeah, because you have 3 hospitals, so many doctors and all that. So you should take minimum 2 crores.
3 crores, 2 crores. And in case, do you think, last question, Do you think when you are in trouble and you failed to produce the document, these professional indemnity courses will pay you for that compensation?
See,
Or they will put some litigation and then they will not help you?
see, this is a sort of a hypothetical situation which we come to know only when somewhere it happens and we have a precedence. We do not know, but logically speaking, they should, because they are bound to.
Because they
bound
say
to
that
that.
lawyer also they will provide. They say everything they will
Yeah,
provide.
liar they would provide. Liar they will provide. But it is very, very important when the litigation is there, you should be very careful to
From
see
your side.
yes, to see to that whatever answers they are putting, it should go through you. Because what happens is that they are much more busy. If you see their diary, it is much bigger than our diary. All the day they will be busy in the court. In the evening, 5 o'clock, they will come back. Then he would relax for a couple of hours. And 8 o'clock, then he would be seeing the file. Okay, 25 cases are there tomorrow. Okay, 5 cases we will take next date. This case we will take next date. So he doesn't have too much time to concentrate and focus on your things.
Yeah,
So
yeah.
you and then what happens is he would prepare some answers and will send it to you. And then you are also busy. Then you are going to
Whenever you receive any communication from registration office, you should always better to take the communication even if the address is changed.
Yes, of course. Of course. Every communication you should take, because otherwise they are entitled to take a one-sided ex parte decision against you.
You should always receive the postal.
Yes, you should receive.
And you should immediately respond in appropriate in association with lawyer.
Yeah. Absolutely.
So even if they ask you to attend, you can send a letter saying that I cannot attend, or you should attend.
Nowadays, most of the consumer forum, at least in Chhattisgarh, they have started that you can do it by the video conferencing. So they would accept your versions by video conferencing when the discussion is to be going on. Documents you have to send it by the courier, whatever usual way is there. But the discussion can occur in the evening.
If the patient has a small residual stone of RIRS, and if he claims 3 crores, the judge can understand that this patient patient is not correct. Is it correct?
Yeah. Correct. See, judges are also, like I said, that you have to be careful and all that. Judges are more, they have a bias towards them, but they don't have a bias towards them to in such an extent that they would feel so stupid. When a small stone is there, nothing has been done, and he is asking for 3 crore, while probably he is just a rickshawala or an ordinary bank staff or something like that. See, if Ambani is asking for 3 crore, it is understandable. So it all will depend on his socio-economical status.
Yeah. So that says that it is not.
No.
So overall, sir, thank you very much. And I clearly take some of the points that the adrenaline gets expired fast. The oxygen cylinder should be filled. The current should not be a problem. Generator should not be a problem. File, don't write it 100% perfect. We concentrate more on file than the original, this adrenal vials, oxygen, and something anesthetist and surgeon quarreling in the theater, talking both in different ways, trying to protect each other. Whether it is whatever case,
that is very important.
Our hospital, we should go together, and you should have some friends, some helpers locally. Should maintain some good environment locally with doctors. This is a multi-disciplinary approach. You should be a good person, and everyone should be willing to help you. Even if there is some problem, they should be able to protect you in such situations. So nobody should face it, but we cannot avoid in 40, 30 years of career, one day or another day, we will face that. That time, these things will matter a lot. I have already faced 3, 4, no doubt about it. Luckily, I came out of it. Sometimes they at last do some understandings outside. We encourage, especially if the poor persons are there, and if unexpected death has happened, don't argue, fight with them. Try to understand. Be sympathetic to patient attendants also. Don't raise the voice, and somehow try to be cool and be sympathetic. Then they will understand. If they are really violent, avoid the situation, and later on you can sit and talk. By the time adrenaline and emotion is controlled both the sides. So a lot of official points are as covered. And I hope this presentation will be useful for all the surgeons, particularly urologists, because our surgeries are not threatening surgeries. Whenever death happens, usually it produces adrenaline and a beat missing, as he said, sir said. That should not that should not completely miss the beat. So be in your, especially second tier, third tier cities and districts, people are forced to operate now because of the competition. These type of talks will be very useful. Since long time I had desire to do with Lalit Shah sir. In fact, I wanted to do under IMA, but that time it was not possible. But this time I could do in pure, so that this link can be shared. And even I will share in my IMA also. This is a crisp presentation of 30 minutes, more than 150. Usually PCNL's RIRS 150 people will attend, but this session attended by more than 150.